I'm delighted to be able to co-chair this second CLL forum educational session today. So we're delighted that Stella's joining us. So Stella Williams is one of the consultant haematologists up in Clatterbridge in Liverpool. I was just getting to Stella to remind me, the Clatterbridge, they've rebuilt their brand new cancer centre, and the haematologists have moved in with the oncologists. And so the patients in Liverpool are very well served with a cutting edge facility. And Stella's going to talk to us about first-line CLL.
Thanks for the introduction. Thanks for the opportunity to speak today. And thank you to everyone that's dialed in to hear about CLL on their Monday evening. A topic of frontline therapy in CLL, which is a wonderful challenge that we have at the moment. So we have really excellent treatments available, but we have a number of them. And so you can go around in circles and think a lot about what is the best option to start as our first treatment option for patients with CLL. We'll talk a little bit about the planned update to the BSH guideline. So that's not actually out yet, and also a little bit of news from ASH included. And so before talking about what treatments we have available and when we want to use them, a sort of reminder about current evidence on treating patients at an early stage. And here I've just said very clearly no, which is a bit harsh, but really there's been lots of trials looking at treating patients that you would normally have in that kind of active monitoring phase, so those not meeting the IWCLL criteria for treatment. And here in particular, this is the CLL-12 trial, which compared ibrutinib and placebo in those patient groups, not those with a very low risk, but any intermediate high or very high risk feature, randomized to have ibrutinib or placebo. And whilst, as you would expect, there was improved event-free survival, their overall survival, there was no difference with a long follow-up. And almost more importantly, there was more deaths in the ibrutinib cohort, and this feels, in this setting, potentially like preventable deaths. So patients that you wouldn't normally give a treatment to, having an adverse event leading to death that is directly attributable to that medication, really would steer you away from wanting to intervene in that group. So when patients do require first-line therapy, our current available agents, I'm going to talk through our 4 options that we have available at the moment and the data to support their use, and then try and look at any information that we have that might guide us in our choice based on those trial results, but then also looking at patient factors and the different aspects that we will consider when we're making our choice of treatment. So starting with venetoclax obinutuzumab. So this is a fixed duration treatment, 12 cycles of 28 days each. When starting this particular treatment, one of the main considerations here is that, at least initially, patients will have to attend hospital for a number of different appointments. So they're attending for their obinutuzumab infusions weekly initially, and then at the venetoclax ramp up, there are, even in those with low risk of tumor lysis, there are a lot of hospital appointments for blood monitoring, certainly with the first 2 doses of venetoclax. The 2 trials that we have data from here is CLL-14. So this is patients with coexisting conditions, and comparing venetoclax obinutuzumab with chlorambucil obinutuzumab, and CLL-13, which is the fitter group of patients, but importantly did exclude those with a TP53 aberration, and that compares venetoclax obinutuzumab with chemoimmunotherapy. The 6-year progression-free survival results here with venetoclax obinutuzumab in all comers was 53.1% versus 21.7% in the chlorambucil obinutuzumab arm. And another result that is now being reported more often is time to next treatment, which is really important for patients. So you've had a 12-month treatment, but potentially even at time of progression, there may be a period of monitoring again. And so 6-year time to next treatment rate of 65.2% in the venetoclax obinutuzumab arm. And so at that 6-year time point, well over half of patients are not requiring further therapy. a little bit about the adverse events that we experience. So commonly cytopenias, though, and in particular neutropenia, though rarely febrile neutropenia. And then infusion reactions is another common aspect that we see with the obinutuzumab. I think using the combination in our centre, it's very rare that we have patients that are admitted with any complications with this treatment. The most common thing we would see is those infusion reactions, which occasionally require admission and very rarely have meant that we've not been able to proceed with the venetoclax-obinutuzumab combination. Otherwise, we do see a little bit of neutropenia. We probably treat ourselves with the filgrastim more than and the numbers, but we haven't really had any admissions with neutropenic sepsis or or those sorts of complications. So generally very well tolerated. Just as along with that, the CLL13 results. And so here, comparing what we have available, so the venetoclax-obinutuzumab, 4-year progression-free survival of 81.8%. versus 62% in the chemoimmunotherapy arm, and similar safety data from this trial. Moving across to continuous therapy, so acalabrutinib, we have Elevate-TN trial. This is either older patients or those younger patients with comorbidities having the acalabrutinib versus acalabrutinib obinutuzumab or obinutuzumab chlorambucil, and this is 6-year follow-up data, and we have results from the acalabrutinib of 62% versus 17% in the chlorambucil obinutuzumab arm. Acalabrutinib continuous therapy, first month, you're basically starting 3 different tablets. So we have the acalabrutinib twice a day, the cotrimoxazole once daily, and allopurinol for that first month. I think that's part of that discussion when we're starting acalabrutinib is about that tablet burden. And that being a continuous treatment until either intolerable side effects or progression. We've generally had very little in the way of problems with side effects on acalabrutinib. I think the most common thing that we've seen is slightly non-specific symptoms, things like arthralgias or a kind of impact on general well-being that can result in dose reductions. But again, very rare that we've had to stop treatment due to adverse effects. Here's the adverse events within that Elevate-TN, and it comments on common things such as headache, diarrhea, and some cytopenias. The diarrhea typically happens early on, can usually be managed with loperamide, and tends to settle with ongoing treatment. And then we have zanubrutinib, the Sequoia trial. So there was an update from ASH in December with 5-year data. So this is untreated patients over 65 or younger and unsuitable for FCR chemotherapy. This cohort, they could not have a TP53 aberration, and patients were randomized to have either zanubrutinib or bendamustine rituximab. And here you can see the 5-year progression-free survival of 75.8% versus 40.1%. Similar safety data to the acalabrutinib, though, and it comments here on COVID as well. A lot of these trials were done during the COVID pandemic, and so it does have an influence on particularly infection rates. We will talk about cardiac effects linked with BTK inhibitors a little bit later on. And then finally, our other available fixed duration option, which is ibrutinib and venetoclax. So this is 15 cycles, 28 days. The main data of the kind of licensed fixed duration treatment with this combination is from GLOW and Captivate. GLOW being those older patients or younger with comorbidities, no TP53 aberrations, having ibrutinib and venetoclax or obinutuzumab chlorambucil, and Captivate was a younger patient group, fixed duration ibrutinib and venetoclax. So there was an update at ASH with some further data from GLOW, with 60-month progression-free survival, ibrutinib and venetoclax of 59.9% versus 17.8% in the chlorambucil obinutuzumab arm. And here's a little bit about the safety data from GLOW. All kind of expected side effects that we see both with the individual drugs and in combination. Our main experience with ibrutinib venetoclax has actually typically been within the FLAIR clinical trial. a reasonable amount of patients have had dose reductions in one or either of the medications, but actually as a combination has generally been really well tolerated. I've not seen any admissions with adverse events, and so a well tolerated combination. Here's the Captivate data showing a 54-month progression-free survival rate of 70% across all cohorts. And then side effects from the Captivate trial it's showing similar to flow data, though less in the way of atrial fibrillation. And then whilst this is not something that we have available to us, I just thought it was important to show the results from FLAIR. So this is MRD-guided ibrutinib venetoclax. So patients had ibrutinib and venetoclax and were monitored, and when they reached MRD negativity, they had that time again on ibrutinib and venetoclax, and that then marked the end of their treatment. And by following this approach, they had really excellent results at 4 years of a progression-free survival of 93.5% in the ibrutinib venetoclax arm. So whilst this is not something at present that we can access, it's just shown such real efficacy. So what does that all mean? So none of these trials are intended for comparison. Lots of mixed populations, lots of differing exclusions, different amounts of follow-up. When I'm seeing a patient in clinic and we're talking about the different options and what I think that will mean for them, just looking at all comers, I would tend to say that there's an 80% chance of response and ongoing remission at 4 years. And I think that just gives kind of a bit more of a picture to the patient of what they can expect. And there's lots of variables in there, and you might be able to be more specific, but actually from the available data that we have, I think that's a kind of realistic expectation. If we want to look more specifically, just a little bit more about the data in those patients dependent on IGHV mutation status and TP53 aberrations. For IGHV in CLL14, 6-year progression-free survival by IGHV status, we can see here that in those mutated IGHV group, median progression-free survival was not reached, as compared to in the unmutated group, that of 64.8 months. And time to next treatment, again, median not reached. 6-year time to next treatment was 79.5% in the mutated IGHV group. And so just really powerful results there, showing that in patients with mutated IGHV, venetoclax obinutuzumab does have excellent long-term results. Just as a comparison, in the trials with the BTK inhibitors, there was less of a difference, but and the lines kind of cross over. So there's less impact of IGHV, mutated or unmutated, on the progression-free survivals, and the same from the Sequoia trial. And then this is just in the ibrutinib and venetoclax combination fixed duration. So here you can again see quite a difference between mutated IGHV and unmutated, with estimated 54-month progression-free survival rates from GLOW of 90% in those with mutated IGHV, 59% in the unmutated group. So I think when faced with a patient with mutated IGHV and no TP53 aberration, there are excellent outcomes in fixed duration venetoclax obinutuzumab, which is a well-tolerated combination, and that can be the way that I would lean towards if we, but taking into account all other factors, which we'll come on to too. And then a little bit about TP53. So here from CLL14, the 6-year progression-free survival results by TP53 status. So those without a TP53 aberration, median progression-free survival of 76.6 months, but those with was reduced at 51.9 months. And here you can see an ELEVATE-TN, so this is acalabrutinib, that there was not such an impact in TP53 aberrations. And Sequoia, this is cohort 2, that was those with a TP53 mutation. And whilst there's no comparator, it shows really excellent ongoing results at longer follow-up. And so in terms of how they then relate that back to patients, and when we're talking about treatment options in patients with TP53 aberrations, I would say that continuous therapy tends to be preferable. So there might be other elements that make us lean away from that. You can have an expected, progression-free survival of 6 to 6.5 years. which with fixed duration treatment would be lower at around 4 years. And so it seems a little unfair leaving only one slide to the patient factors when we've had all those slides on the data. But there's a lot that we have to consider when we're looking at our 4 options and discussing those with the patients. And so there are certain comorbidities that may lean you away or towards a certain treatment. So looking at renal function, tumor lysis risk, but also then looking at cardiac comorbidities, those patients on anticoagulation or with a bleeding tendency. And then there's the elements of those treatment options and clinic visits and how that looks to people. So when I think with the majority of patients, when we are approaching time to treatment, there is a window where you can start to have those discussions. And so I take that opportunity to ensure that those prognostics have been checked. So we've got as much information as possible and we can help guide patients in their treatment choice. My experience is that most people want a guide and want a steer towards what we think would be best for them. But then taking into account their priorities and their preferences. And so, as I've said before, certain circumstances, I would tend to lean towards particular treatments. So those with a mutated IGHV normal FISH might lean towards venetoclax obinutuzumab. Those with the TP53 aberration lean towards continuous BTK inhibitor. And then a little just about the cardiac side effects of BTK inhibitors. So acalabrutinib and zanubrutinib, we get a question a lot of which to use, which I'm afraid I can't answer today. But just in general, in terms of the risks with the BTK inhibitors, we've got much clearer guidance now on how we should be approaching patients when they're due to start a BTK inhibitor. And the risks of adverse events are less with the second generation medications. But we have these ESC guidelines that basically tell us all patients starting a BTK inhibitor should have baseline cardiovascular assessment, physical examination, and an ECG. And only those with a high or very high risk should have an echocardiogram. And that's your patients with history of heart failure, cardiac history. We're very lucky in Liverpool that we have really excellent cardio-oncologists available to discuss patients with. So if we are ever uncertain or worried about particular cases, we can link in with them very quickly. They will see our patients and arrange for any appropriate follow-up, and they will help give us a steer on whether we can safely start a BTKI. The other element within that is that of anticoagulation and BTK inhibitor therapy. It's not always a problem, but it can be that on starting a BTKI in a patient on anticoagulation, that bleeding phenotype can worsen. I think kind of across the UK, there's slightly differing practices, and some people will quite happily reduce, if it's a direct oral anticoagulant, will happily reduce that to a prophylactic dose to then start a BTK inhibitor and enable the two to run together. We wouldn't typically immediately do so, but we would leave the anticoagulation, start the BTK inhibitor, and really close monitoring for any significant bleeding. And occasionally we might have to dose reduce, or there are occasions where we would have to stop anticoagulation, and it's just a risk-benefit discussion with patients and keeping cardiologists in the loop with our decision making. And here, acalabrutinib or zanubrutinib, we get asked a lot. Personally, I don't feel able to give a strong preference for one over the other. We've used both really effectively in patients for frontline treatment of CLL. There is this MAIC, which is comparing data from relapse refractory setting, where they showed that there was no difference in progression-free survival, but potentially that there was a lean towards acalabrutinib in terms of less hypertension or hemorrhage. But this is not, it's meant to be kind of hypothesis generating rather than definite fact. And like I say, personally, I would find it very hard to recommend one over the other. It is worthwhile noting that if one BTK inhibitor is not tolerated, it is worth trying the other. If we've gone down that line of choosing continuous therapy, then if one is not tolerated due to side effects, then the other may be better suited. So moving on, so BSH guidelines update, it kind of encompasses what I've talked about today, and these are not, it's being kind of, it's in progress, and this is not fact or things that are definitely going to be included, but really focusing on the benefit from checking prognostics before initiating treatment, the consideration of comorbidities, and a discussion with patients about fixed duration or continuous therapy based on all those factors that contribute there. Clinical trials if available. And then in those without a TP53 disruption, the 4 options that are NICE approved, and just a kind of mention of caution of use of ibrutinib venetoclax in older patients with comorbidities. A comment that there are other treatment options that have been shown to be efficacious, though not currently licensed. And so the combination of acalabrutinib, obinutuzumab, acalabrutinib venetoclax, and also MRD-guided duration ibrutinib venetoclax, like in the FLAIR trial and those results, not currently available for us to start. And then those with a TP53 disruption, continuous BTK inhibitor may be preferred, but essentially you can choose anything you like, which is how we stand now with treatment for CLL, frontline treatment for CLL, is we do have all options available to us. A mention of the ESMO guidelines, just because they do differ a little, and in the blue boxes, this is their kind of order of preference based on how they describe expert opinion. So they have a real preference for kind of fixed duration treatment, other than in those with a TP53 aberration. So they've set aside, so TP53 aberration should have continuous BTK inhibitor, ideally frontline. All other groups, venetoclax, obinutuzumab, other than fit or younger patients with an unmutated IGHV for whom they recommend ibrutinib and venetoclax. So it differs a little. It's a bit more of a steer towards that fixed duration treatment in most groups. And so an update from ASH. So there was some additional data there at the beginning, that some updates from some of the trials we've seen. I'm just going to show data from 2 of the oral abstracts that were presented there. So the Amplify and one of the BGB studies. So this is Amplify, so fixed duration acalabrutinib with venetoclax, with or without obinutuzumab, versus chemoimmunotherapy. This was in a kind of fitter patient group, so you're excluded with a SIRS score of over 6, and importantly did not include those with the TP53 aberration. Patients randomized between the 3 combinations, and this is, I'm just highlighting this because in the chemoimmunotherapy group, a number of patients did withdraw from the study, which is understandable in the setting of targeted therapies. You can see why, when assigned to chemotherapy, one might have more patients withdrawing from study. Here we have the 3-year progression-free survival curves showing in the AVO group, progression-free survival of 83.1%, in the A and B group, 76.5%, and in the chemoimmunotherapy group, 66.5%. And here there's some more separation in the unmutated IGHV subgroup, with the AVOs showing a progression-free survival of 82.8% versus 68.9% in the A and B arm. This trial wasn't designed to compare the triplet, doublet with acalabrutinib combinations, but rather compare acalabrutinib combinations with chemoimmunotherapy, much closer together in the mutated IGHV subgroup. They did some censoring for COVID deaths, just because this did have an impact on their results, and so a clearer benefit there for the AVO group when censoring COVID-19 deaths, and an improved overall survival. This was seen more marked in the acalabrutinib venetoclax arm, but then when censoring for the COVID-19 deaths, it was both acalabrutinib arms showed an improved overall survival compared to the chemoimmunotherapy group. The side effects were, as one would expect with this combination, so reasonable amount of neutropenia, headache, infusion-related reactions with the obinutuzumab group. Febrile neutropenia was rare in the acalabrutinib groups. And then looking at those of particular interest, so things like atrial fibrillation, rates were very low. Major hemorrhage, again, low numbers. And so just looking at those results from Amplify, there's clearly an improved progression-free survival with the acalabrutinib arms compared to chemoimmunotherapy, which is something that we're not going to be starting in our patients at present. An improved overall survival with the acalabrutinib venetoclax arm, and then when censoring for COVID-19 deaths in both the acalabrutinib arms, it was a well-tolerated combination. Looking at the curves, it does look like the unmutated IGHV group may benefit most from the triplet, but we need longer follow-up. It'll be interesting to see how things are then borne out in time. And then finally, this is a BGB study looking at the combination of sonrotoclax and zanubrutinib. And so here it was a kind of dose-finding study. So they were looking at different doses of the sonrotoclax with zanubrutinib. There was the sonrotoclax ramp up and after a zanubrutinib lead-in, and the option of stopping the combination at around 15 months. So in that fixed duration setting. Looking at adverse events, there were no deaths, and there were some discontinuations of one or either medication. No tumor lysis was seen. There was neutropenia seen, but this didn't lead to significantly higher rates of infection. And with very short follow-up, there was only one progression event in the lower dose sonrotoclax arm, and that was with a Richter's transformation. And so this is a well-tolerated combination, no new concerning side effects, and a very high response rate. This combination in this trial has led to the Celestial study, which some centres may well have participated in. It's recruited really quickly and is now fully recruited, and that's looking at a fixed duration combination sonrotoclax and zanubrutinib against venetoclax obinutuzumab, and it'll be really interesting to see the results of this. I think it's only going to give us all of these trials and all of these results are only going to give us even more options for our frontline therapy, more discussion, more but certainly a good problem to have when we think back to there only being the option of chemoimmunotherapy, and we're just not even talking about using that now. We've got such excellent treatments available. And on that note, that is the end of my presentation, and I'd just like to invite discussion and questions.
Stella, that was a fantastic talk. Thank you very much. And thank you for giving us some of the ASH updates. Just to reinforce that point that patients with early stage CLL who are not particularly unwell with the condition, that there is there's an international consensus that there are no gains from treating early. And I think because this course is attended by people fairly new in the hematology journey, I think it's worth stressing that point, isn't it, Stella? And you did show us the German data randomizing ibrutinib against placebo and the deaths and the small numbers in the ibrutinib arm, but remind us that these are medications that come with side effects. I think before we get into these differences between treatment strategies, I have noticed nowadays that thing, we've had this conversation before about patients who are troubled with the fatigue and tiredness that is one of the hardest symptoms to pin down, and they've got a white count of 50 and small volume nodes. In the days gone by, and you'd never give them immunochemotherapy. But there is that slight temptation because our treatments are easier to tolerate. Stella, have you ever had your arm twisted when you're thinking, I don't really want to rush in and treat, but I'm going to? They're 75. What are we saving them for? If I can give, they might just have a much better quality of life in a couple of years.
Yes, and yes, I have. And actually, in my experience is one particular patient that it kind of just bit me a little, that I was convinced that there was no other cause for fatigue, and we started BTK inhibitor, and it made no difference. And then and I just but it didn't cause any adverse events, adverse effects, but it didn't improve that fatigue. And so I think fatigue is really challenging across the board in all of lymphoma, CLL, or even just in general practice, because it's so hard to pin down what the cause is. And so while beyond a tiredness screen and knowing that someone's got active CLL, there is definitely a temptation to try CLL treatment.
And I have to say, because I've given this example before a couple of years ago, getting caught out with a chap who had endless discussions, and he came up to start his ACALA, and he came in and said, right, we're going to start today. And he says, well, you know what? Since my GP got me going on insulin, I'm feeling so much better generally. I thought, oh, general medicine, never forget your diabetes, thyroid, and all it's easy. Just a few pointers. Renata.
Could I just jump in, just what a
Yes.
comment kind of to what you just discussed? I had a patient, and I only saw him today, who obviously suffering from fatigue because he's got stage C CLL, and he read the information sheet of BTK I gave him, and one of them was tiredness. And he was, well, no, I'm not going to go on these tablets because you're giving me information and it's going to make me even more tired. So it's just trying to, yeah, how common is tiredness with the medication? You know, what is the tiredness caused by CLL? So it took a while to say, well, yes, let's just start treatment and see what's what.
I think it is gone. Let's bring John in because last week John told us about his journey. I love that. By the way, John, I've told quite a few patients this week that we've got someone who's had CLL for longer than they've been alive. What was it? You gave the phrase last week, and I've quoted that a couple of times. More years with CLL than without CLL.
Yeah, that's right. Yeah. I haven't had it for longer than I've been alive, George. That would be a medical first.
Said that in the clinic. No, but John, let's bring it because you've been through cycles of treatment. You recognise CLL tiredness better than anyone, I'm sure. Tell us about it and how you've tried to work that one out with your consultant.
It's not a get out. It's multifactorial. It can be as a result of the treatment. It can be as a result of the condition, and you've just got to work through it. It's unexpected, but I think that the longer I had been in various cycles of treatment, various different treatments, I began to get a knowledge of what my body can do and what it can't do and how I react. And I'm not saying that it gave me a sixth sense, but it certainly gave me a sort of informed feeling as to what was actually causing. And then the cliche within our circles of just treating your body as a battery rather than being on mains power, realizing that you had a limited capacity and then utilizing that capacity to best effect. That in turn gave you the mental advantage of at least I've achieved something rather than I've achieved nothing and I'm still knackered, to put an unmedical term into the mix. But I was really pleased, Stella, to see the way you dealt with and brought into the debate the patient factors, the vulnerabilities, the priorities, and the preferences, because they're three separate subjects, and all of them are important. And dealing with patients who have their preferences, the preferences may be actually detailed by or guided by their working life, whether they're retired or working. And I was in a support group last week, and one of my fellow patients there was talking about trying to manage taking this medication with his shift pattern. And it wasn't something that I had realized. This person works a very early shift, and trying to get his routine of his medication in with an alternating shift pattern posed a challenge to him that up to then I hadn't considered. So that's just a few pointers.
Valid point, Stella. You're going to come back on that.
Oh yeah, no, I was just going to say absolutely, and also just other responsibilities. So I think we've had a number of people who care for other family members, and so have not felt able to attend sometimes for the intensity of appointments, with some of the fixturation combinations, and so yeah, we do have to take that really into account, because the most important thing is that the patient is at the center of it all, and so whatever suits them best is how we should.
We're going to drill down into individual strategies in a second, but Lelia, I'm not letting you off the hook because you're tracking what comes through the CLL Support Association questions. Before we leave this topic of not treating early stage CLL, we always get a feel that people being diagnosed at the beginning of this journey is one of the most challenging things. And we all have examples in our clinics of patients who struggle even over 6-12 months to adjust to this concept. Give us your feel from the patient association. Is this still an ongoing challenge, a recurring theme? You know, I have leukemia, surely I must be treated.
Yeah, absolutely. I think that's part of the pressure to treat is if you tell somebody they've got cancer, the first thing they want to know is, what are you going to treat me with? And it's really difficult message to communicate that you've got, and leukemia is the only word people hear initially from CLL. And then to be told that you're not going to be treated is a really difficult thing. So that is one of the issues to sort of balance that pressure with, is actually explaining to people that there are reasons why you're not treated, and there is treatment available further down the track. But actually, I've just been looking at the data from our survey last year, and I was quite taken aback. We've got data from about 1,000 respondents, and they'd rate quite highly their knowledge of CLL treatments. And that's regardless of whether they're in the watch and wait. So the people who go online and answer surveys are relatively well informed, I think, surprisingly well informed, actually, about the treatments, or they feel that they are. I mean, this isn't an exam to find out what you know. It's just but I think that feeling is important. So when you've got people...
I'm going to interrupt because I had recently tried to move a patient back to primary care with really quite early stage CLL, and very reluctant, and I couldn't quite work it out. My specialist nurse said what they really like when they come up to see you in a clinic, even if it's only once a year, is to get the updates, to hear what's happening at the conferences, to get a personal view. Because a lot of the patients, even the early stage, are very interested, aren't they?
Yeah, and if you talk, absolutely. And I've got friends who are GPs, and most of them have never seen anyone with CLL. So you have to bear in mind that it's much more reassuring to see somebody whose day-to-day job is CLL than to see somebody who might in their entire career seen one or two. Maybe I'm slightly exaggerating.
No. The challenge we have, of course, is the clinics we know well, but we're not going to get into that one.
I know.
Now, Francesco, you have joined us. Welcome to the panel. So, Francesco, we've got 15 minutes left before we're going to hand over to you. We're going to keep you involved. We want to drag you into these conversations, but we're now going to drill into how we make decision-making in the clinic. And I know we're going to have some MDT discussions next week. But Stella, you started off with a pretty decent pitch for mutated IGHV CLL. Look, why not just give them Veno? Why are you going to agonize about all your other options? And you actually put a good argument. You very rarely get somebody admitted. You accept infusion reactions, but once they get through that, most patients tolerate it well. And I'm guessing across the UK, that has become fairly standard practice. And Stella, I guess you're just, let me just, before I bring in Francesco Renato on that one, is that basically the Clatterbridge pitch?
I don't think we're super strong about it, but that is, in the absence of, when you're trying to have something to guide you and the patient is there wanting a steer, but not having a particular preference, then yes, that is the kind of, I lean towards that option.
I+V, the GLOW trial, we've all followed it. Of course, we have certain reservations in certain patient groups, but those mutated patients with ongoing follow-up, they're not really relapsing. And it doesn't seem to matter if they've got low-level disease. They're just fine. They're just not relapsing and they're quite well. Doesn't that push us a bit more towards I+V for them? Renata, are you using it in your clinic, perhaps for some younger ones? Or?
Yes, I'm using it because it's so easy. Obviously, my default, just like Stella said, is a fixed duration. And usually I start discussion from, can I give this patient VO? Because obinutuzumab frontline is an extremely good antibody. Obviously, we can't use it second line. We can't use I+V second line. And it's probably, although we've got clarity data, and I know, may I say that, Lilia, you've been on clarity? So we've got a personal experience here. So clarity in second line is amazing, but I don't think we're going to have it for a long time. So it's sometimes very difficult because obviously there are those two combinations. We can't just rehash second time round. So for me, should I give this patient VO or I plus V? And I usually start from the fixed duration. I will leave the maintenance type of treatment to the patients like we discussed, touched on last week, the high risk group where they need this trickle of inhibition kind of continuously to keep the disease at bay. And as you said, I plus V, we don't have obviously head-to-head data. It would be interesting what CLL 17 will show us because there is some fixed duration in those. There will be, and there are poor risk patients there versus maintenance. So, but that's not going to read out till 2027. I think it's supposed to finish quarter in last quarter in 2026, if I'm correct.
Francesco,
I can make my
mutated IGHV, younger patients. Are you leaning more towards VO or are you allowing some for I plus V?
So with David in Southampton, we've like to use a policy which has been a bit of a hybrid based on the fact that we know what I plus V will do if we are using an MRD guided approach. And the bottom line is that probably we all know that at the end, the limitation of I plus V is that it is finite and it's been chosen to be given for that duration of time, not really based on a good biological rationale. And it will be part of my talk, by the way, of that. We really want to suppress the two mechanisms together. In the mutated CLL, what the scenario that you generate is actually that I plus V will have a very long time, despite the fact that you do not obtain eradication of the condition, right? So you certainly favor the activity of venetoclax by giving a BTK inhibitor. You put the cell even more energized than what it is. It is definitely the approach. It is the duration of the treatment that needs to be reviewed, in my view. To choose between I plus V or venetoclax plus obinutuzumab in the mutated CLL, actually, it's reasonable to think that Ven-O in first line, it does make perfect sense. Again, there are studies at ASH where they also suggest the need of giving Ven-based treatments until maximal results, so until a minimal residual disease reduction. So I wonder if that is the problem that we are facing, which is more of a financial and social problem as opposed to a biological issue. What do you all think about that?
Yeah, I think, Francesco, you raise an important point, but of course, it's important for us to remain educationally sound for the delegates on this call, because in Europe and the UK, I plus V is licensed at 15 cycles. I think those of you in private practice might be doing like some of us are trying to persuade Bupa et al. To let us continue, but obviously that is helped by international guidelines suggesting, as you say. Have you managed
ever?
We'll converse offline about that one, but it is not licensed and approved therapy to go beyond 15 cycles. I hear what you say, because I think we've all seen the FLAIR data, amazing data, but we've also probably all been in meetings with Americans who are saying, actually, if you've got a 38-month follow-up with up to 6 months treatment, 6 years treatment, you're still looking at a continuous treatment trial at the moment. You've got to see how that data pans out. But undoubtedly, in terms of published phase 3 data, the FLAIR data stands out. Remarkable data for young people. I think we would all love to have that opportunity to treat. That does allow us actually to segue. Stella, you presented Amplify. Now, of course, I was going to come back to you with the unmutated, but let's flip it around. Let's go to amplifying that A plus V data. Again, mutated patients, very appealing, isn't it? And if we are, I think we're probably in agreement that swapping the BTK at least will help with toxicity. If Pete Hillman was here, he'd say, remember, BTKs are not the same. And A plus V now might not be the same as I plus V in terms of efficacy. But if we say toxicity is better, you look at that data, maybe that is a very appealing next step for CLL management.
Yeah, I think I find it a little bit hard thinking about giving ibrutinib in the setting of having the second generation BTKIs. But like you say, the combination with venetoclax, that's the only option at the moment. But just knowing across all the trials with ibrutinib, there are much more significant side effects, and knowing that there is a better tolerated BTK inhibitor, and so in the Amplify data showing really excellent results, then we'll have Celestial come through with zanubrutinib and some venetoclax, which is a bit of a similar combination. I think it will certainly be attractive. It runs that challenge of but again, your obinutuzumab, the only time that you can get it is at the first front line. So you need, if you were just given all options at all points of treatment, I still wouldn't know what to do, but but it would be nicer.
I take the point. I mean, the triplet data, I remember seeing the German triplet data, and one of my patients traveled to Dublin to actually get on CLL13, was randomized to triplet and ran into quite a few problems. And then seeing the AVO, particularly that excess mortality with COVID, and it just reminds us that we're always asking that question, do we really want to crank up our first line intensity? Are we really seeing the benefits? I know the world of myeloma, they tell us repeatedly, they add the extra drugs, they go for different pathways, and it keeps translating into benefit. But in the world of CLL, perhaps some mutated it does, but we've got to be a little bit careful, haven't we? Francesco, I see you nodding wisely. Are you a triplet man, or are you a nervous person?
I am a Hamlin's or Katowski's man. The less you touch the patient, the better. Which makes sense.
Chlorambucil then in Southampton.
Well, no, not chlorambucil, but we can drop the category of treatments in which we have the best survivals so far. Actually, there is clearly a temporal component that ibrutinib was used before the others. But we still are aware of the NIH data that the long survivals of an ibrutinib are clearly a characteristic group of patients with mutated immunoglobulin genes, rather initial indolent behavior with a slow progression. So there are margins to reduce the treatment based on stratification on those patients. There are needs to add treatments to some selected group of individuals who have a really aggressive condition, which are not the majority. So I would go less than more, personally, particularly in the mutated.
Right.
The balance is not the biology of the condition, but is the recipient. So what is his... Renata, rightly so, was telling me off about the word fitness. If we think about fitness in the German style, but if we reapply the word to the fact whether the patient is fit for a BTK inhibitor because of cardiological fitness, then we have the problem of what can we give to this individual based on their overall conditions. And it's more that biases our decision, isn't it? Otherwise, we wouldn't go for a finite treatment.
No, wise words. Renata, let me drag you in. And I'm aware that time is ticking away. So I'm going to segue, Renata, a couple of comments on triplet, but I do want to get your view on unmutated IGHV in day-to-day practice, because I think for me that is a bit challenging, because I'm going to paint the picture. I guess we were very involved with the early Elevate TN trial when it was a CERTA 007, whatever it was, or I forget my numbers. And we've still got patients who are now 8+ years, 9+ years, unmutated IGHV, still taking their Acala, feeling well, haven't missed a beat, think that it was the best thing since sliced bread. And it still sort of always reminds me back to John and Leila's point about the patient, that if you have someone unmutated IGHV CLL, second half of their 70s, does it just not make life easy for us, for them, for everything, just putting them on a BTK inhibitor and walking away? But I don't want to frame your answer. How are you approaching those patients?
I think if I've got it, I remember Lilia a few years ago was a bit concerned putting all, as she put it, all eggs in the basket. And I still remember that comment because indeed, once we use AVO, we kind of use it all we can use. But there was an interesting poster on the latest ASH showing that actually complex karyotype maybe is more significant than TP53, because obviously TP53 at the moment is, across all the studies with multivariate analysis, is the most important still poor prognostic factor. But we know there is a subset 2, 321. Those patients do really badly. There is a subset 8, those patients who have very high risk transformation to Richter's. We really don't know what to do. So I think if I have a young patient, I probably would like to throw proverbial everything at them, because you kind of want to use everything what you've got available. Now, whether, to be honest, I don't think we will have AVO available because of the probably of overall survival we've seen in Amplify. I think AV, we probably will have it approved, fingers crossed, this year, and would be truly practice changing for us and for the patients. So I'm not sure whether that answers your question.
Well, yeah, no, you make wise comments about the triplet. I agree. I'm like Francesca. I get nervous about trying too hard and making someone more ill, particularly quality of life is so important.
But yeah, it's absolutely right. Mutated. Why would you want to throw that at mutated patient 13q? No, as little as possible.
But then just before, because we can't leave first-line treatment without at least talking about unmutated IGHV patients, where the data always remind us we can't walk away from it, whether it's I+V or Veno, but fixed duration, these patients relapse. Of course they do. They're biologically less stable. And so inevitably in the clinic, assuming the patient is saying, whatever you say, doc, you've got to tell me. We are juggling that sort of fixed duration versus continuous. And I must admit, in the younger ones, I still tend to go for fixed duration because I suspect we all naturally do. But I think in my own mind, I have a bit of a tipping point, maybe around mid-70s type thing, maybe a bit younger with these unmutated, that I just tend to put them on a BTK inhibitor. And I think you could argue there's a bit of lazy thinking there. I'm assuming that things are going to improve, Perto will come along, all the other things that, why am I going to overthink it when you know that there's a decent chance they're going to get 5, 6, 7 years, and then think again. But Renata, is that lazy thinking? Are you still pushing fixed duration in perhaps your older patients for unmutated IGHV?
No, I think, I'm with you on that. I think if you've got unmutated, because there is always hope something will change. And we've seen such a huge revolution in our CLL practice. Perto is definitely coming. So we've seen really amazing bispecific data in ASH, epcoritamab. I mean, some response rate was very relapse patients, single agent. I mean, obviously we can't touch it at the moment, but those hopefully, epcoritamab been used in other lymphomas. CLL has kind of became an orphan for that sort of treatment. But I think, as you said, the maintenance type of treatment is buying us at the patient's time. And I think it's
with a drug that's generally not impacting on their quality of life for most people. Yeah,
exactly.
Stella, any final comments on that before I hand over to Renata to chair the second session?
Oh, challenge. I don't think so. I think we've covered it all. Like it's really challenging in that we have at the moment 4 excellent options. I don't think we can be entirely prescriptive. It has to be a case by case discussion. I think we have steers in certain disease factors, but then also it's always dependent on the patient at the end of the day. But all good options.
It's difficult for us. The one I just it occurred to me, I forgot to say that I have heard people saying that perhaps more bulky disease, they prefer the I+V in these younger over a venetoclax obinutuzumab fixturation. I sort of buy that, really. I think the BTKs are very good at debulking. Sorry to add that in right at the end, but it is a point that's come up in various discussions previously.